and a lot of workshops. This is first advanced pediatric laparoscopy workshop have been done in LRC with the EPSA, and this is he was teaching whatever part in Egypt. This is in Tanta. He was in one of the workshops, again in Saudi Arabia, and this is in Kuwait, and this was with Monzer and Philip Zvai, and this was with Juan Augustine again in Kasr Al Aini, and this was the first rabbit neonatal laparoscopy workshop done in the Middle East. It was in the LRC in presence of Hesham and Dr. Inam and a lot of other friends, and he was sharing science worldwide in Arab countries. And this is during Clinical Las Condes in Santiago, Chile. The workshop was there last year. And again, another one of the courses. We conduct more than 20 courses in the last 3 years. And this is during the launch of the IBIG Middle East chapter in presence of Aida Qahtani, Monzer Haddad, Marcela Perez, Professor Sameh Shahata. It was in November 2015. And this is the short video of that time. Hesham was from the start, one of the beginners. And this is the last workshop was in February 2020. And this was the first TOT for pediatric laparoscopy, not just for the juniors, but this was for seniors. TOT workshop in LRC in his place. I have to, it is a long friendship in training between each other, me and him, and you are missing him alone. And I have to thank, as I thank Dr. Saad Mahdi, who will give a short talk now. I thank Dr. Tamer Ashraf, who was Dynamo for preparing this session. Thank you for all. Dr. Saad, you can take now this point.
بسم الله الرحمن الرحيم. شكرا أستاذنا الكبير الدكتور شريف لإتاحة الفرصة ليا. أنا آسف إن أنا محضر الكلمة بالعربي، إنما أعتقد ده مش مشكلة. يعني هو في الحقيقة يعني ثناء وليس رثاء للدكتور هشام الساكت. فنحن نرثو المتوفى، ولكن الأحياء عند ربهم يثنى عليهم ولا يرثون. هو حي بعلمه وعمله وخلقه وتضحياته. هو في الجنة بعمله وعلمه وتفانيه وتحمله للمرض. هو حي في قلوب مرضاه قبل أسرته وزملائه. هو عند الله إن شاء الله مع القديسين والشهداء. هو الأب والأخ والزوج والصديق والطبيب المرحوم الأستاذ الدكتور هشام الساكت. من مفارقات الزمن الذي نعيشه أننا قد لا يتسنى لنا معرفة الكنوز من البشر إلا بعد رحيلهم. وفي حالتي هذه لم يسعني أن أتشرف بمعرفة الأستاذ الدكتور هشام في حياته، ولكن ما سمعته عنه من طيب ما قيل عنه وذكراه الطيبة وزملائنا الأطباء جعلني أتخذ منه رمزا، وجعلني أبادر باقتراح عمل هذه الأمسية الاجتماعية العلمية تكريما لما قدمه في مسيرته العلمية والحياتية. وأنني أتقدم بخالص العزاء لأسرته الصغيرة متمثلة في زوجته الدكتورة شيرين الجيار التي يشرفنا حضورها في هذه الليلة، وأسرته الكبيرة من زملائه الأساتذة العظام وتلاميذه ومرضاه. وأشكر الدولة بهذه المناسبة بإطلاق اسمه على مركز التدريب التي كان يرأسه تخليدا لذكراه العطرة. وأشكر أساتذتي المحترمين لتلبية الدعوة وبقبول مبادرتي لتكريم اسم الأستاذ الدكتور هشام الساكت. وتحياتي.
شكرا. Thank you, Dr. Saad. And now Dr. Sharif and Dr. Shireen take the chance to give the personal data, please.
شريف هيبتدي ولا؟
Start please يا شريف.
Okay. Dr. Shireen, you can go on.
Okay. I want to start with many thanks for every and each one contributed in this webinar. Show love for my husband, Professor Dr. Hesham Elsaket, and this will help keep him alive in our hearts and memories. Dr. Hesham wasn't only a wonderful husband or a giving, adorable father or a church faithful friend, also a great, clever surgeon, despite so many patients in need. Hesham had the ability to make everyone feel comfortable, secure, and loved with his greatest strength, wisdom, and help. I was such a blessed woman to have him as my soulmate and to share his lifelong tough journey, starting with his graduation with highest honor in 1990, then his residency in Abu Rish Children's Hospital from September 1992 till September 1995, passing his master's degree exams in 1995, signed excellent. Then he got his MD of General Surgery in May 1999. He then got his diploma in total quality management from the American University in Cairo in 2005, and he had his senior exclusive program in May 2010 through the Future Generation Foundation from India Institute of Management. Throughout the years, he was gradually promoted and became a professor of pediatric surgery in Al-Qasr Al-Aini Medical School, Cairo University, with so much hard work and time. It wasn't an easy mission to be a distinctive surgeon between all the clever ones. He did it with continuous non-stop work and with a very clear vision of what was attainable. He showed remarkable exclusive ability in achieving what he set out to do. His great work was during the period when he was the director of Learning Resource Center. The center was integrated in 2006 to robust training facility that provides an educational environment that combines stimulating academic study, effective skills, training, and sound research procedures. The LRC educational projects have partnered with some of the most renowned academic institutes in Europe and USA. Dr. Hesham was keen to make all provided courses internationally recognized and accredited. And he attained accreditation from the American Accreditation for Continuous Medical Education and from European Association for Endoscopic Surgery, from the European Surgical Institute, European Resuscitation Council, European Resuscitation Council, American College of Surgeons, Royal College of Surgeons, Association for Assessment Accredited of Laboratory Animal Care, and that was in 2018. This is not all. He had so many administrative positions. For example, former vice director of a new children's hospital, and lately, 2 years ago, he became the vice dean for community service and environmental development, where he started a campaign of medical convoys all around Egypt. He did almost 25 ones from November 2018 till March 2020. From north to south, east to west, covering so many rural areas, saving many children, and providing medical services in different specialties. Till the COVID-19 pandemic started, he was one of the leaders to provide the strategy plan of facing the dangers of the disease in Cairo University hospitals, when unfortunately he got the virus and passed away. Our time together may have cut short, but the happiness we shared together will last a lifetime. God bless him till we meet in heaven. Thank you for all. Can we share the LRC video right now? Dr. Sharif?
Yes, you can start sharing, please.
Okay, we can see this LRC that he got his name now, and he deserves it.
شكرا يا دكتورة شيرين. You can stop screen sharing now.
Okay.
And Professor Ahmed Bezaki, we thank Professor Mohammed Osman Al-Khosh for giving the name of LRC to our late Professor Hesham Elsaket, and he apologized to be present today. And so will be now Dr. Ahmed Zaki will present Professor Dr. Mahmoud Al-Mitani.
It's a great honor to present a friend and a colleague and the director of Ain Shams University, Professor Dr. Mahmoud Al-Mitani, as well as Professor Dr. Ashraf Omar, the Dean of Faculty of Medicine. Professor Dr. Mahmoud Al-Mitani is director of Ain Shams University. He's a professor of general surgery and is the founder of the liver transplantation program in Egypt. Professor Dr. Ashraf Omar is the Dean of Ain Shams University, Faculty of Medicine. He is the CEO of Ain Shams University Hospitals, and he's the professor of general surgery. Both of them had the insight very early in the COVID-19 problem to set up a hospital for university staff or university personnel. Not only one hospital, actually as the time went by, there are 3 hospitals. One of them is a field hospital which was built by resources outsourcing from by the efforts of Professor Mahmoud Al-Mitani. The second deed that they did, that these 3 hospitals were free. Not a single patient was asked to pay any money during the stay of COVID-19. And actually, this achievement had helped us to seek the help of Professor Mahmoud and Professor Ashraf during the disaster of Professor Dr. Hesham Al-Gayar and Professor Dr. Hesham Elsaket and Dr. Shireen Al-Gayar, which ended up in the loss of our dear friend, Professor Hesham Elsaket. In my name and the name of EPSA members, being the past president of EPSA, I'd like to extend our thanks to them. And I leave the word for Professor Dr. Mahmoud Al-Mitani, director of Ain Shams University. Professor Mahmoud.
شكرا دكتور احمد. Thank you very much, Dr. Ahmed, and thank you to all the administration of the Egyptian Society for Pediatric Surgery. For a while I haven't with you, but my dear friend, the late Professor Ala Faiz, is a friend of and a brother for all of us, for all of you, and for me personally. Through him, I had very strong ties with the pediatric surgeons in our country and maybe in the world. And we had a long path together with Dr. Ala Faiz. And actually, through Ala integration and with a lot of passion and enthusiasm to his profession, to the surgery at large and to the pediatric surgery especially. And Ala, as an elder brother for me, has always praised Hesham, and it is, I think all what he told me about him was even not enough, because it happened that I knew Hesham later on more closely. And we became real friends. He impressed me by his passion. You just mentioned at the beginning and the introduction about his passion to training and to taking care of our youngsters and our young surgeons. And he was a really dedicated surgeon. So he didn't only honest about the great deal of his time for this mission, which I believe is the most important mission for all of us as in the academia at large and surgery, to transfer to our young generation all what we know, and to be keen to make them even more clever than us. It's not only like us, professional advance. Hesham called me in such critical time and difficult time for all of us. The COVID-19 pandemic has hit the whole planet without any exception in our world. And Egypt was no exception, of course. And community and in Egypt for the being either, I think, I think is not negligible at all aspects, whether the financial aspect and needless to say, education and the healthcare practice is really is going to change. And there is a total paradigm shift, I would say, in education that we are all witnessing now nowadays. He called me, and as usual, he was very brave. And when he got the COVID-19 illness, he tried to manage at home alone for, I don't know, a few days or so. And we know that he was originally asthmatic and having, so he was a very sensitive person. One of the important comorbidities when we talk about COVID-19. And he told me that I think I need a hospital, I need oxygen support, and I need to be hospitalized urgently. And of course, we responded to him immediately. And I want here to praise his wife and his family, and to extend my deepest condolences to all of them. They were all very brave and stood beside him. His wife got the same, maybe the same day or one day after, COVID-19 as well. And maybe she was asymptomatic or very mild symptoms. She needed not to be hospitalized, but she insisted to be hospitalized just to be beside him. So, Dr. Shireen, you are a very brave person. And يعني اسمحي لي I'll speak just 2 words in Arabic. اسمحي لي أتقدم لك بخالص العزاء لحضرتك ولأسرتك ولأسرة القصر العيني الشقيقة كلها. هي شقيقة الكبرى زي ما كان دايما بيقول لنا سامح فريد. وإن إحنا كلنا بعتبر أنا نفسنا في أطباء عين شمس وأطباء قصر العيني فريق واحد، وأطباء كل الجامعات المصرية الحقيقة. فخالص العزاء لأسرة القصر العيني، جمعية جراحة الأطفال وأسرته الصغيرة. وعمرنا ما هننسى هشام، هذا الجراح العظيم الخلوق اللي أعطى من وقته كتير لمهنته ولزملائه ولتلاميذه، وإحنا كأصدقاء وزملاء عمرنا ما هننساه. ويعني هذا قدري. أنا عملنا حاجة يمكن حضرته معانا قبل كده، تأبين الدكتور علاء فايز برضو من جراحة الأطفال، رائد عظيم في جراحة الأطفال، وهشام كان معانا يوميها. النهارده يعني بنفتكر كلنا هشام بكل الخير، وأتمنى لكم وقت نقلب بقى على العلم، ومش عايز أطول عن كده، وإن شاء الله نلتقي قريبا بإذن الله.
دكتور محمود قوي. وانا معلش انا عارفه ان ده مش وقتي المفروض ان انا اتكلم فيه، بس بجد ده يعني فرصه ان انا اقدم ليك كل الشكر على الدعم اللي حضرتك عملته لنا نفسيا ومعنويا ويعني وفي الموقف حضرتك معانا. وانا عمري ما هنسى لحضرتك الموقف ده ابدا. هشام كان حضرتك بالنسبه له عليه جدا. شكرا ليك انك حسيت بيا في الوقت ده ويعني استقبلتوني احسن استقبال الحقيقه في المستشفى. We did all the effort، بس يعني الحمد لله قدر الله وما شاء فعل. ميرسي ليكم جدا، ميرسي للميموريال الرائعه بتاعت النهارده، يعني وان حضرتك حضرت بنفسك. ميرسي قوي.
واجب عليا ولا شكر على واجب دكتوره شيرين، وتحت امرك في اي حاجه. وانا متاكد لو الموضوع كان معكوس كان القصر العيني هيعمل كده مع اي حد في عين شمس، فاحنا كلنا واحد،
احنا اسره واحده. اكيد اكيد. ميرسي. شكرا.
دكتور شريف بيه ده، اتفضل يا دكتور شريف.
The next speaker is Professor Dr. Mohammed Sami, our Vice President of Cairo University for Community Services, and he was one of the cornerstones of the medical campaigns that were held by Cairo University, going further east to further west, north and south of Egypt, giving medical help and giving medical guidance and screening for pediatric surgery services, other services of medicine. The help was given by him
financing and directing and guiding the campaigns that went to, as I said, to the Red Sea area, to Marsa Matruh, to Noba, Halayb, and Shalatin. And we had the honor to join him in our last medical campaign that was in Noba, I think in last February in 2020, which was the last medical campaign before Hesham was hit by the COVID and passed away. Professor Mohammed Sami.
Thank you, Dr. Sharif. My words in Arabic. مساء الخير على حضراتكم. والحقيقة إنه بدعوة كريمة من الجمعية المصرية لجراحة الأطفال وبحضور قامات من قيادات التعليم العالي وقيادات كليات الطب في مصر وأساتذة عظام من الأطباء والزميلة العزيزة الدكتورة شيرين الجيار وأسرة العزيز رحمة الله عليه الدكتور هشام الساكت. أنا بيشرفني أن أشارك اليوم في هذه المناسبة، والحقيقة أنه قليلين هم من يرحلون بأجسادهم ويقلدون بأعمالهم، ومن هؤلاء بكل تأكيد الزميل العزيز رحمة الله عليه الدكتور هشام الساكت شهيد الجيش الأبيض اللي جسد مسيرة من العطاء مكتملة الصور في مجالات متعددة سواء في العلم أو في الإدارة أو في خدمة المجتمع. خليني أكون صريح مع حضراتكم إنه لا أخفي القول إن كلماتي تعجز عن التعبير بحق زميل عزيز خوفا من التقصير عند وصفه أو وصف مآثره بعدد من الكلمات المحدودة. حقيقة الدكتور هشام له أفضال ومآثر عديدة على كلية الطب وعلى جامعة القاهرة وعلى زملائي سواء من أعضاء تدريس أو العاملين في الجامعة. والدكتور هشام رحل مبكر لكنه ترك سجلا حافلا بالإخلاص والأمانة والحب والعطاء في خدمة وطنه، كما ترك فراغا من الصعب ملء. إنجاز لي أن أتحدث عن الدكتور هشام الساكت في العلم والإدارة، فمما لا شك فيه وكما رأينا من التعليقات ومن المقطع المصور بصماته واضحة وعلاماته مضيئة على مركز التعليم المتطور التابع لكلية طب قصر العيني، والمعروف اختصارا بالLRC اللي تولى إدارته من عام 2011 واللي شهد على تميز الدكتور هشام رحمة الله عليه. حصل خلال فترته على شهادة الاعتماد الدولي من الرابطة الأمريكية للتعليم الطبي المستمر كأول مركز مصري وأول مركز في الشرق الأوسط يحصل على هذا الاعتماد. واسمحوا لي أني أنتهز هذه المناسبة وأتوجه بالشكر لمعالي الأستاذ الدكتور محمد عثمان الخشت رئيس جامعة القاهرة اللي بادر بعد يعني ساعات قليلة من وفاة الدكتور هشام بإصدار قراره بإطلاق اسم المرحوم الدكتور هشام الساكت على مركز التعليم المتطور LRC، هذا الصرح العلمي تقديرا لدوره وتخليدا لذكراه. على خدمة المجتمع وتنمية البيئة، الحقيقة أنا زاملت دكتور هشام لمدة عام تقريبا، تشاركنا سويا في الإعداد والتنظيم والإشراف على القوافل الطبية والقوافل التنموية الشاملة، وأشهد الله على أن هذا الرجل المحترم كان يقوم بواجبه بمنتهى الأمانة والإخلاص وبمنتهى الحب والسعي إلى عمل الخير. وكان من حظي أن أنا سافرت بصحبته في عدد من هذه القوافل، كان آخرها زي ما تفضل دكتور شريف إلى المستشفى العسكري بأسوان ومدينة بنوبة بالتعاون مع القيادة العسكرية للمنطقة الجنوبية. والحقيقة لمست الدكتور هشام الإنسان والإنسان الراقي بمعنى الكلمة، المخلص الأمين الساعي إلى الخير، يعني صفات لا يتسع الوقت لذكرها. صحيح رحل عنا دكتور هشام، لكن سيرته العطرة هي اللي بتخلد ذكره وتخلي قلب كل من يعرفه وأدعو حضراتكم بالدعاء له بالرحمة والمغفرة وبنيل الدرجات العلى في الفردوس الأعلى. وأشكركم شكرا جزيلا، والسلام عليكم ورحمة الله وبركاته.
عليكم السلام ورحمة الله وبركاته يا باشا، وحضرتك يعني خالص الشكر للكلمة الجميلة اللي حضرتك يعني أوجزت فيها وجمعت كل ما يمكن أن يقال يعني في يعني حق الأخ العزيز والمرحوم الدكتور هشام الساكت. وشكرا لحضرتك، ويعني كنا نتمنى طبعا وجود أستاذنا الدكتور محمد عثمان الخشت، ولكن اللي هو يعني اعتذر لوجوده خارج القاهره، وحضرتك يعني ملأت هذا المكان، ونتفضل بخالص الشكر لحضرتك يا باشا. شكرا جزيلا. Our next speaker is our dearest Dean of Cairo University, Professor Dr. Hala Salah, and an eminent professor of pediatrics and neonatology in Cairo University. Dr. Hala.
Good evening, everybody. Thank you very much for this evening. It's really very difficult to me, and I cannot imagine that today we are gathered together to say all these words about Hesham. I know Hesham more than 15 years. He's a colleague in pediatric departments. And when I was appointed as a dean, the first one I selected in my team was Hesham Elsaket, Allah yarham. Who's all his years working with everybody in Cairo University and Faculty of Medicine, really he's very dedicated. I can tell everybody that 8 a.m. in the morning, you will find him in his office, planning, working, before maybe most of us arrive to work. He's really, really dedicated and devoted to his work. He's an unreplaceable person. He has a good vision at his work. I can't imagine that I lost him till now. I feel that the team lost one of the cornerstone, and I think he has his own way that many people can use it as a guide for them in their life. He was very, very stable person. Is his management. He's a good vision in all aspects of his work, I can't add any more for the wording you say, but really, really, he was an ideal person. He's an ideal colleague. He was very, very devoted to his work. He was fascinated by his work. He's very loyal to Faculty of Medicine, Cairo University. All the time he's thinking how he can upgrade LRC, how he can improve the training, how he can add more and more to the pediatric surgery department. I lost a friend, I lost a colleague, I lost my brother. But let me say this in Arabic, that السيرة بعد العمر. Everybody will remember Hesham Elsaket. He's an icon in our school. And my condolences to his family, Shireen and the kids, and all of us. And I thank you again for this very difficult evening to me. But he deserves more and more nice wording about him, because he did a lot for our school, for his students, for his colleagues. Thank you very much. Thank you, Dr. Sharif. Thank you.
Thank you very much.
Thank you, Professor Hala Salah, for your nice words. And now, Dr. Ahmed Zaki, please, for Dr. Ashraf Omar.
Yes, I'll call again for Professor Dr. Ashraf Omar. He's a professor of general surgery and the dean of the Faculty of Medicine at Shams University, and he went hand in hand with all the activities and the achievements that were done through COVID-19, and he was there when the Elsaket family reached out with their hands during that crisis. Professor Dr. Ashraf.
بتقدم بخالص العزاء لأسرة الدكتور هشام الساكت ولأسرة كلية طب القصر العيني. الحقيقة يعني ما فيش كلمات تقدر تعبر عن فقدان هذا الإنسان العظيم. أنا اتعرفت عليه واتقابلنا كده مرتين أثناء تحضير الكوريكولوم الانتجريتد كوريكولوم الجديد. إنما يعني أكتر حاجة لمستها إن الإنسان ده في خلال فترة مرضه أنا اتعرفت عليه من خلال حب الناس الشديد ليه واهتمامهم كلهم بيه. ما تخيلتش إن يعني إنسان يكون كل الناس مهتمة بيه بهذا يعني الاهتمام الشديد. زي ما بنقول حب الناس ده هو أجمل حاجة في الدنيا اللي بتبقى دايما بعيدا عن المناصب وبعيدا عن أي حاجة. خدمة الطلاب وخدمة المرضى وحب الناس هو ده أفضل حاجة فاز بيها دكتور هشام. عزائي للدكتورة شيرين وأسرته، وعزائي لأسرته الكبيرة اللي هي طب القصر العيني. شكرا.
شكرا دكتور أشرف بيه. And now we'll come to scientific part of this session, the middle of the session, and we have 4 eminent speakers. Our first speaker will be Professor Aid Qahtani. Professor Aid Qahtani, a well-known Arabic and Saudi and international pediatric and obesity surgeon. And since Hesham was his main interest is minimal invasive, the 4 subject of scientific session will be on minimal invasive. Dr. Aid Qahtani was the president of the International Pediatric Endosurgery Group, IPEG, and currently is president of the Arab Association of Bariatric Surgery. And he will give a talk on bariatric MIS in children. Please welcome Dr. Aid.
Thank you so much. It's really an honor and a pleasure to be with you today. And thanks for organizing this important event, which is, I think, the least we can do for a person who really contributed significantly to minimally invasive work in the region, and not only in the region, but even worldwide, through his contribution to IPEG. I don't know if you see my slide.
Yes.
Okay. I think you can see how much Hesham has contributed a lot. He's one of the pillars and the founders of the IPEG Middle East chapter, and he always contributed to many committees in the mother IPEG and the programs in different ways, whether the program committee or educational committee. And as we have seen in the videos, when you see such a center in training, it does not exist in the most developed country. We have been in US, we have been in Europe, we have been, and I am sure our colleagues from different areas. And the reason we see this huge center that incorporates many type of minimally invasive skills learning is because mostly of definitely the support of the university, but Hesham Elsaket being the leader of the center. We can see his courses, and again in his video has been also shown, has been everywhere in the region, contributing to his colleagues, and also being humble, being a leader, in the whole criteria of being a leader. So thank you so much for everybody contributing to the memory of this person who really has influence in many people's life, whether current or future. I'll be talking about bariatric MIS in pediatric patients, and just an overview because I know we are focusing on some important topics, but at least to add to what has been done by Hesham and other people in the region. We know obesity is a problem and growing problem in the region. In Saudi Arabia, and also if you look to Saudi children, more than 2 million are obese. But if you look also in the region, we are worldwide, globally, we are thinking about more than 50 millions, and it will reach to 250 millions in years to come. And it carries with it huge amount of comorbidities. in different, from disabilities, psychological, diabetes, hypertension, metabolic, all issues that we usually see it in adult age, but now currently we see it in childhood. Even COVID, we know COVID by itself is a problem, but here, as you can see, up to 20% of those who really seen by and having major comorbidity are related to being obese. Sleep apnea is an issue, and it has been shown almost 3% in normal people, but 40% of those obese are having sleep apnea, which is life-threatening as well condition. And diabetes, as I have mentioned, it's really significant prevalence, and it's almost very short period before developing diabetes. You just developed insulin resistance, you have hyperinsulinemia, you go to diabetes within 2 years. That's very short period. And again, blood pressure, by just having one BMI increment, you will be having almost 4.5 millimeter of mercury being increased in your blood pressure. Health-related comorbidities, unfortunately, these people are quality of life is really affected by obesity. Liver, and NASH, and others. We don't see it in, you're supposed to see it in adults, we see it in children. Thickness and vascular problems. It's also related to obesity because of hypoxia, because of other problems related to their disease. 1 in 5 person from some studies show that they have renal problems. Solution, either balloon, which is only above 12 years of age. We cannot do it before that. So we prefer to be in elderly, in older age. And it's not that effective, but at least we can expect about maybe 10 kilogram weight loss. But it is not persistent. 6 months and they will regain their weight. And there are a lot of study on this. Then we have a new techniques called endoscopic gastroplasty. And we have published the first paper on this and in the American Journal of Gastroenterology. Now it shows up almost 18% total weight loss. It translates to almost maybe 15 to 20 kilogram weight loss within 2 years. And they will continue maintaining this hopefully afterwards. And it's less invasive, it's reversible. So I think it's very important consideration in this age group. We have done it in 150 cases till now, and the comorbidity is less. Simply, I will show you a clip of this. Usually you go inside the stomach through the mouth, the scope, as I hope you are seeing the video, but anyway, you go through the mouth and you go to the stomach and you suture the stomach. It was, in our cases, it was standardized clinical pathway, which again, for those interested, they can go for this pathway. Sleep gastrectomy is an option, which I think it's the best option when we are really having super obese or they are really having comorbid condition. We look to BMI percentile, we look to other things, but this is important things to consider. We have published a lot in this to show it's effective, it's safe, it does not affect the growth. You can start doing it in 5 years and 10 years, there is no problem. So there are a lot of studies that we have published in this field to show how safe it is. This is a video, but I will not take you in this, but in general, you go and you pass there in the stomach a tube. This is a calibration tube. And then around this tube, you go and transect the stomach. Almost you leave 50% and you remove up to 75% of the stomach. Again, we have long-term up to 10 years follow-up on our patient. As you can see, we have 500 patients who passed 7 years. And they have up to 60% excess weight loss maintained at that time, with resolution of comorbidities, significant comorbidity resolution. We study the growth, does not affect the growth. In fact, if you are doing it, you will have a better better growth, up to 10 centimeters, as you can see. This is for those who have done, did not do surgery. This is for those who done surgery, almost 10 centimeter difference in growth with follow-up. It is in all age groups. So growth velocity in those who passed 7 to 10 years, it is the same. There is no, this is this score. So there is no difference in this score in terms of you follow them. They will grow as much as the others in a very good manner. And adult versus adolescent, we are showing the comorbidities improving, and they resolve their comorbidity in the first 3 months to 6 months, as you can see. This is a paper we study how long does it take to resolve diabetes, hypertension, and this. It doesn't take a long time. Almost 3 months, you will have it resolved in 90% of cases. Also, bypass has been studied in teen labs, and it is really effective long-term as well. However, the comorbidity is really higher. If you look to the problem with bariatric surgery in adolescents, how much it helps them, there are a lot of improvement in their weight in terms of BMI, in their pain, in their function, in their quality of life. Significant improvement. And pain or joint pain after surgery, significant improvement, reduced by 40% within 12 months. So musculoskeletal is improvement in all aspects. You can think of it, medical, musculoskeletal, psychological, significant improvement in all aspects. I will not go in details, but there are a lot of publications in this regard. And whether bypass, whether sleep, we think sleep is better, and resolution of comorbidities, and also bypass as well. However, sleep is better in terms of quality of life, maybe, and comorbidity. There are a lot of publications in this regard. Banding, we don't think it's really something to stay. Up to 85% of patients who underwent band, they go for another procedure eventually within 2 years onwards. So it's not a long-term issue. In summary, bariatric surgery and endoscopic bariatric therapy are safe and effective option for children and adolescents with obesity. In children with adolescent or adolescents with class 1 and 2 obesity or BMI percentile 120 to 140, we think endoscopic is an excellent option. When you go for more than 40 and above with comorbidities, you go for sleeve gastrectomy as a second option. Thank you so much. And again, thank you for having this meeting to contribute to colleagues, a person, and God, inshallah, bless his soul.
Thank you, Professor Aid, for your nice illustration. And as we mentioned, we have superstars in MIS, and our second speaker will be Professor Munzer Haddad. Just to introduce Professor Munzer, he is a friend. He was one of the icons of minimal invasive surgery worldwide and in the IPIC, and was in the Chelsea Westminster Hospital, Imperial College London, and currently is the president of the British Association of Pediatric Surgeons, and will give a talk on thoracoscopic TOF repair. Please welcome Dr. Munzer. You are a share screen, you are a co-host. You can share your screen.
Hello, good afternoon. I would like to thank the organization for considering me in participating in this memorial webinar for our colleague and friend, Professor Hesham Elsaket. I have known Hesham for over 6 years now through the minimally invasive surgery and through his enthusiasm and dedication for training and education. Hesham was a friend, a colleague, a good family man, husband, and father, as well as over all this was a human being. I am sure that the community of pediatric surgery in Egypt and worldwide has lost a pillar in education and dedication for pediatric surgery. I have chosen this topic because when I was in Cairo at the Learning Center, he actually mentioned to me about tracheoesophageal fistula and the thoracoscopic approach and the simulation. So that's why I would like to dedicate this to his memory. And I would like also to convey my deepest sympathy and regards to his wife, children, and the family, as well as the Egyptian Association of Pediatric Surgeons. Can I share the screen?
You can share by yourself. Just click on the green square down, share your screen.
Yeah, okay. Right. I would limit my talk, or shorter talk, rather than a longer one. But as we know, esophageal atresia and tracheoesophageal fistula occurs in 1 in 3,500 live births with a slight male predominance. And it is commoner in prematurity. And 50% of these neonates are associated with other anomalies, mainly cardiac anomalies, in about 15 to 25%. And there is the association of Vactral as well as Charge syndrome. The etiology is unknown exactly, but it's actually speculated that is due to genetic factors and teratogenetic stimuli, and also to intrauterine environment causes. The diagnosis usually and investigations usually are prenatal through the ultrasound, where there is evidence of polyhydramnios and absence of fluid-filled stomach, and also small abdomen with distension of the upper pouch. And that is usually, if it is available, it is confirmed with MRI, fetal MRI. Postnatally, it's the excessive salivation and inability to pass a nasogastric tube, and X-ray, which actually showed curling of the tube in the upper pouch. And also we do an echo to identify the position of the aortic pouch. Some people do bronchoscopy earlier, but I usually tend to do the bronchoscopy at the time of repair. These are the types of the fistula, and the first one is the normal anatomy. The second one, where there is esophageal atresia and communication of the fistula with the trachea to the stomach. And the history goes back to 1679, where the first description was by Thomas Gibson through an anatomy cadaver. In 1899, that was the first gastrostomy done for a patient with esophageal atresia by Hoffman. Then 1936, Landman performed 4 primary repairs. And in 1939, the first report of fistula ligation and primary repair by anastomosis done by Robert Shaw, but these unfortunately did not survive later. But the first successful operation, open surgery, was done in 1941, and that was done by Cameron Hickett. The operative approach is actually either by paraprofile or by the thoracotomy is extrapleural and or transpleural. It is shorter in operative time, and there is an adequate visualization and standard endotracheal intubation. While the thoracoscopy is always transpleural, it takes longer to do the procedure, has got very superior visualization, and there is an anesthesia challenge, and the anesthetist should be experienced in these procedures. Why do we do thoracoscopic approach? Because it's better cosmesis, less musculoskeletal complications, less ventilation time, and less stay in the NICU, and also potential better function of the esophagus, although it has not been well proven. So it is minimally invasive surgery, and with the improvement and miniaturization of instrument, we now use 3 millimeters for the repair, and usually we search for associated anomalies especially the rotation of the aortic arch. And also we, as I mentioned, experienced and confident anesthetist should carry the procedure, and the surgeon should be experienced to work in small spaces. The absolute contraindications is hemodynamic and respiratory instability and significant prematurity with a weight of less than 1.2 kilograms. The relative contraindication is significant cardiac defects and significant abdominal distension. And the key points, the baby should ideally be over 2 kilograms, bronchoscopy to identify fistula and gauge the distance should be carried out. And there's usually a period of desaturation, but if you are patient and the anesthetist is experienced, that will be fine. And usually the metal clip are as good for ligating the fistula as the suturing. And the important thing is to know when to convert and how to train juniors, which Hesham was very keen on training these. The almost a prone position, and we draw an anterior and posterior axillary lines. We usually use the gravity to actually get the lung in a way. Surgeon and assistant stand in front of the infant and mark the port positioning. And the first thoracoscopy was done by Jacobs in 1910, so it's not a new thing, but the thoracoscopic repair of esophageal atresia was first done by Tom Loeb and Steve Rothenberg at an IPIG meeting in Berlin in 2000. I hope this will work, but if it doesn't work, I'll have to get out and get it from sorry, it was working a minute ago. Okay. Can you see the screen?
Yeah. Share screen again. You can share screen yourself. Okay.
You can't see it now?
No video. Make it on the desktop and running, and make your screen sharing.
Okay.
Yes, it's okay now. We are seeing it.
Okay, this is the, you can see the video now?
Yes.
Right, this is the position of the ports. This is used to be the 5 millimeters, and now we use the 3 millimeters, but the scope is the 5 millimeters. And you can appreciate how a clear and better visualization of the structures intrathoracic rather than the open technique. Start with the thoracoscopy. So we go around and identify the azygos, identify the ribs, and identify the lung, and start with incision in the parietal pleura around the azygos vein. And nowadays we avoid ligation of the azygos vein if it is not in the way of the fistula. And we dissect the fistula and identify the fistula and its connection with the trachea. Then we deal with the azygos vein. This is a previous video where we carried out ligation of the azygos vein. And once that is done, you can do that with either diathermy or ligation and cut in between the ligatures. And you can use the vicryl, and once that is performed, then you turn to the fistula itself. and identify the fistula and dissect all around the fistula and its connection with the trachea, and you will ligate the fistula. As I said earlier, you can use clips, but actually it's more or safer to use a ligature, and I usually use the Ethibond 2O, which is an absorbable material to ligate. I usually do 2 stitches there and cut in between, and I make sure that there is not a lot of pouch left into the trachea, and then cut. That's the lower end, which is the upper part of the distal end of the esophagus. And once that is done, you turn to the upper pouch. I'm just putting another suture here to make sure that there is no leak from the trachea. Then we identify the upper pouch, and in this time we ask the anesthetist to push the replugal tube. And once that's identified, it's dissected, and we made sure that bronchoscopy has been done and there is no upper pouch fistula as well. So the upper pouch usually is hypertrophic and very thick. And once that is identified, we make an incision, and usually I leave a little bit in the posterior part, which I can, it's like a stent or something to make sure that the upper pouch doesn't disappear. And I measure the distance in between the lower and the upper pouch, and then I start the anastomosis. It's a full thickness anastomosis, including the mucosa and the wall, and it's uninterrupted sutures. And these sutures are usually, you can use the PDS, the 5-0 uninterrupted sutures. And make sure that when you actually do the sutures, you don't ligate or stitch the I will probably, for the sake of time, I will stop once I put first suture. Usually we do 4 sutures posteriorly and 3 or 4 sutures anteriorly. And I try to do most of the sutures extra or outside the esophagus rather than inside the esophagus. I don't think there's any, it doesn't matter if you do it inside as well. I'll stop here and exit that and go back to
stop sharing and return to the PowerPoint presentation.
Yeah, yeah.
I think you took your time once there already.
Okay, I've just sort of.
Okay.
Can you see it?
Yes, but make it PowerPoint, please.
Is that a new share?
Yeah, you have to have new share, yes. Yes, okay.
Okay, you can see it now.
Yes, clear.
Okay. It's not advancing anyhow. I'll just mention a couple or one report from Helicom, where there had been 104 patients reported. And the main thing that he actually mentioned that 37 patients had suture ligation and 67 had a clip ligation, and he didn't have any problem with the clips. He had recurrent fistula in 2 and had mortality in 3. And the mortality was due to necrotizing enterocolitis and congenital heart disease and esophageal disruption. The conversion was in 5 patients due to right aortic arch, intraoperative desaturation, and relatively long gap, and 1 patient who had 1.2 kilograms and too small to continue. The other thing which I would like to mention is that the large experience is now by Dariusz Batkowski from Poland, from Warsaw. He has done over 160 cases of TOF thoracoscopically, and he's avoiding the ligation of the azygos and having minimal complications and recurrence. He had also the experience of thoracoscopic redo, even 5 times in 1 case. And he also had the experience of applying intrathoracic traction in long gap esophageal atresia. Just to mention, because of Hisham's love of simulation, this is the simulation doll that we use for the esophageal atresia repair. And this is the position. And this is how our trainee train on that. And this is the azygos, this is the trachea and the esophagus. And I will stop here for the sake of time. Thank you very much for giving me the opportunity.
Thank you very much, Munder, for your nice presentation and illustration. You can stop sharing now. And actually, our third speaker is one of our best friends. He is very known for his humor, his kind words. He is the immediate past president of the IBIC International Pediatric Endosurgery Group, and he is well known. He visited Egypt many times, and he is chairman and professor of pediatric and adolescent surgery in Graz, Austria. Welcome, Professor Holger Thiel. And as usual, I think there will be a surprise in his presentation. You can share your presentation, Holger. Come.
Dear Professor Shehata, dear friends in Egypt, dear family of Professor Hesham Elsaket, dear friends of the Cairo University, and dear friends from the Egyptian Society. It is my great honor for 2 things, to say a few words of respect and of appreciation about Professor Hesham Elsaket tonight. The first ones are the official ones. As we've heard tonight, he's been a strong motor, not only of education, minimal invasive surgery within Egypt, but far beyond that, actually reaching the world of IPEC. IPEC is very grateful to what he has done, to what all you have done in the Middle East chapter. But as in all developments, it takes certain visionaries, people with skills and good hearts, to be the first front runners, and he certainly was. So IPEC misses a very, very wonderful member. My respect to the family. The second are almost as important to me, which are personal words. As Professor Sheffer-Hatter mentioned, it's been a privilege to coming to Egypt, not only to see the country develop in terms of MIS, but also to meet some of the nicest friends on earth. Good-hearted people, skilled, and also a good sense of humor. And that was Hesham to me. So it's my great honor tonight to say a few words. I was asked to give a presentation, but we've heard two brilliant presentations already. Academic presentations, data, and I think I have the privilege to simply show a few cases where he would have loved to be, where he probably would have had fun, as all of you, to just dive in and make a nice surgery and probably have a nice word and a glass of tea afterwards. I'll share them with you on behalf of him.
You can share your screen now, yes.
Okay. Shared screen seen?
Share, we can see you.
Okay. So 3 cases just to have fun tonight in memory and memoriam of Hesham. The first case is a 1.5-year-old boy with watery diarrhea syndrome. Obviously, as seen in the right video and in the right ultrasound, he has a lesion at the right adrenal that is producing all kinds of hormones. It's producing vasoactive impact, the peptide, dopamine, noradrenaline, and adrenaline. Why don't we go into the data and then go to surgery? It's a beautiful lesion at the right side of the adrenal gland. If you look closely, you will see, well, there could be some vascular compromises and an interesting vascular situation for the MIS surgeons, maybe because the adrenal vein derives from the hepatic vein instead of the subclavian, the inferior venal caval vein. And I put together, for the sake of time, just a video of about a minute for each one of these 3 cases that I'm showing, not to show off, but again, just to have fun together tonight. You obviously see the lesion, mobilization, first at the inferior part, and now comes the fun part. This is the hepatic vein to the segment 6, and the adrenal vein does not go into the inferior caval vein, but it goes into the liver vein. Hesham would have had fun to do that. He would have had fun to simulate it first too. Okay, and the rest is typical adrenal surgery. On the right side, you just go along the inferior vena cava, and with the help of the ligature, you mobilize the lesion completely, you bag it, and out it is. Okay. Another nice case where Hesham and all of you would have had fun to do it together. Now, this is an adolescent female, 17-year-old, presenting with a hyperindense abdominal lesion, which is right here. On diagnostic, you may wonder, well, is it a renal cyst? Is it an adrenal cyst? Is it a splenic cyst? It probably is a pancreatic cyst. It turns out to be a Franz tumor. Franz tumor is all well known to you. It's nothing unusual. It's a pseudopapillary tumor of the pancreas. And the interesting thing about any Franz tumor is, A, the location. How difficult is it to resect it? Pancreatic lesions in the pancreatic head are much more difficult to resect than in the body of the pancreas, but also the benignity of it, the oncology, which ranges from totally benign to extremely malignant with local recurrences and distant metastasis. So the answer, the surgical answer to any Franz tumor is complete resection. And to this one, it is complete resection and best with preservation of the spleen. Why don't we do it together tonight? So this is the initial aspects, obviously to the left of the abdominal cavity, the omentum still above it. You can see pancreatic tissue right here. You see the lesion right there. And slowly you simply develop it with the finesse of a hook. The fun part comes when you take a look at the lesion close to the splenic artery and vein. Again, the message is to preserve the spleen and its blood supply. And since the location is so favorable, you just take an endo-GI longitudinal to the vessels, preserving the blood supply to the spleen, and out it is. Not a difficult case, certainly a fun case to join and share. We oversuit the stapler line. And for the sake of time, just a third one, not a fourth and a fifth, just a third case, showing the beauty of MIS and showing why Hesham dedicated his life to MIS, because it is certainly for the benefit of the patient, just like Professor Al-Katani and Professor Muntahada showed, each one in different and very interesting situations like bariatrics and EA. Final case, 15-year-old boy. He is a great soccer player in town, one of the best ones actually in the league. And over the summer, his performance decreased. He went to the GP, and the GP found increasing inflammatory parameters. Couldn't make anything out of it. Found maybe a hypochromic microcystic anemia, but the most important finding on ultrasound, and I'll skip that and go directly to the MRI, were two intense lesions in the abdomen. Obviously, this one close to the right colonic flexure. Obviously, this one further posterior, somewhere close to the stomach, to the colon, maybe in the retroperitoneum. Again, the right-sided lesion anteriorly close to the colon, and the left-sided lesion right next to the kidney and to the pancreatic tail. Not another Franz tumor. We biopsied the tumor and found an inflammatory myofibroblastic tumor. Actually, we had to look at the literature to understand what this is and what this means for us. It's a mesenchymal tumor, mostly built out of these lymphocytes, plasma cells, eosinophilic granulocytes, basically infiltrated tumor with cell infiltration of inflammatory cells. Genetic confirmation, the answer to these IMTs is complete surgical resection. Now, I haven't seen many of these. You wonder, well, is that a case for MIS? But at the end of the day, the advances of MIS at this point, Hesham would say, is, well, with one axis, you reach to the left and to the right. You leave the left lesion and the right lesion. Why don't you go for it? And that's what we did. I'll invite you again to show that. It's a minute clip only. And after the biopsy, the first lesion you see is this one. Attached, obviously, after the open biopsy to the abdominal wall. Let's just leave it and see whether we can resect it off. Complete resection is mandatory. Whether we can resect it off the colon. Obviously, an easy one. So if we had to convert to open surgery, all we would have been left is the left side, sparing the patient at least one side of the laparotomy. We didn't know where this would take us, but we went for it, making sure that no viable cells are left. Here's the more demanding lesion on the left side. Obviously, this is the stomach, this is the liver, this is the ligation of the ligament at the greater curvature of the stomach. And slowly we develop the lesion, not knowing where it takes us, not knowing where the blood supply comes from. This is the gastroepiploic epicate, and obviously one of the major vessels derives from it. And interestingly, you will see in a second renal artery and veins. Right there. Pancreas. Okay. I don't want to prove any point. I don't want to be too academic tonight. This is not the reason of the meeting. The reason of the meeting is just to show respect and friendship. It has been a great pleasure meeting all of you, but especially for tonight, Hesham. And on behalf of his IPAC family, I would like to thank again the organizing committee for giving me the personal opportunity to show these deep words of respect and gratitude. My Egyptian friends are very special to us, and especially to me. And I've lost a great friend when Hesham went for COVID. Thank you very much. We will miss him. Good night.
Thank you, Holger, for your, as usual, nice presentation, because you are a special friend. Now it will come to our last speaker in this scientific part of the memorandum session will be Dr. Inam Raboui. Dr. Inam Raboui is the current IPEG Middle East Chapter President. She is a chair and chief of pediatric surgery in King Fahd Military Hospital in Jeddah. And she is a well-known friend to all Egyptian surgeons, and especially for Hesham. And she will present today single incision pediatric endoscopic surgery cholecystectomy. Welcome, Inam, please. Come in.
Yes, can you see my
Yes.
screen?
Yes, okay.
Yes.
Go on.
Good evening, ladies and gentlemen. I'm really honored tonight to be with you sharing this very special memoriam for our friend, our brother, our great surgeon, Dr. Hesham Elsaket. From 1st of May, when we lost him, until today, I think all of us still, we have the pain and sorrow in our heart from his loss. We just have to pray for God to really help us to come over this sadness. Dr. Hesham was a great friend. I knew him for 10 years now. We have been always working together in Jeddah or in Cairo for the workshops and for MIS and for IPIC. We really have lost a great surgeon, a great person, and my condolences for Shireen, my friend, and his daughters and son, and I hope time will heal and lighten the pain we feel all. I don't want really to make it long, more than that, so we will move to my talk tonight, which is, I will speak about single port, what adult before, when they started, they were calling cells, single incision laparoscopic surgery. Children, they call it single incision pediatric endosurgery. And it has been reported in 1992 when laparoscopic appendectomy using a single umbilical puncture was done. And the cells appendectomy in pediatric was first performed in Izmir in Turkey in 2005. The equipment for SIPs or cells, there are different kind of company ports, like Covidian, R-port, Concepts, Triport, Olympus, and Gel Point. We, in my center, we are using COVID cells port, this blue one. We use Gel Point for a sleeve gastrectomy. So a SIPS cholecystectomy has been reported before in 1998 in adult, and the approach failed in the beginning to gain popularity for several years. It might be, especially in pediatric, it might be because before there were, it needed certain instruments because of the difficult technique to be used and the limitation of instrumentation. What is the advantage of SIPS? It's cosmesis, easy of tissue retrieval, like in splenectomy, because if you are doing splenectomy and you are doing fenestyle incision, I think it's an open surgery. It's not laparoscopic. If the combination procedure, like we know, as you know, sickle cell disease, thalassemia is common in our region, and sometimes we need, if we want to take the spleen and the gallbladder, if they have stones, it's we do it from one incision. Now we can use the standard equipment and do not violate natural orifice and the surgeon's domain. What is the disadvantage of sepsis? Is it more painful? There are studies which say more pain, and we didn't notice that. We discharge the patient same day, like post-appendectomy. Cholecystectomy, they stay 48 hours. It's violating principle of ergonomics, like it's same like conventional laparoscopy. The hernia in adult, it's they notice it in our series when we do our SIPS. We don't notice that much hernia, not a single even one. Wound infection, we didn't see it. Maybe also I have to mention something regarding the hernia. Children usually they have a hernia, and we correct the hernia when we use the same incision. The learning curve is as the same as conventional laparoscopy, and the cost effectiveness, it's even if you are using not using ligature, you are using hook, diathermy, or so it's the same or even less expensive. How you develop SIPS? By team working, by workshops, which Hesham, God bless his soul, we were doing a lot of workshops and the industry support and innovation. It's all this can develop this SIPS procedures. What's about pediatric SIPS in general? As you can notice here, the main operation done by SIPS is appendectomy. It's more common, and I didn't actually include these assisted SIPS. Like there are people who are doing above 100 appendectomy SIPS, but they are doing it, they take the appendix out from the umbilical and they do it, but it's assisted. It's not SIPS, not complete SIPS. Here is just maybe just to save time about some of the literatures. So what's about our experience in our center about single incision or SIPS cholecystectomy? We have, because we are the only center in the area, maybe in the Middle East, for SIPS. So we are using, our resident used to do cholecystectomy, appendectomy, even splenectomies. So by the way, I have nothing to, no conflict of interest. Those are not all of our team, but we have published this paper in Journal of Laparoscopic and Advanced Surgical Technique in 2019, September, where as background, this actually few centers worldwide have advanced SIPS for pediatric age group. And to our knowledge, this is the first study assessing the safety of SIPS cholecystectomy in children with sickle cell disease performed by resident. The aim of our study was to determine the feasibility, safety, and expediency of SIPS cholecystectomy in children with sickle cell disease performed by surgical residents. Our method, our material, I said we are using Covidian port, as you can see in the first picture, and we did retrospective study of all cholecystectomy done from 1st of April 2011 to 31st of March 2018. We compared outcome of SIPS cholecystectomy done by fellows and residents. And we were using this long 50 centimeter laparoscope to decrease the collision of instruments, and we use straight regular instruments. In the beginning of our series, we were as you will see later in the video, we were introducing the needle from the abdominal wall, pick it up inside the abdomen, and then we bring the gallbladder and suture it to the wall. But recently, maybe 3 years ago, we were just taking the needle inside and bring the gallbladder and take it from outside in, out, like you can see in this picture. This is the video. I hope it will work from here. Yeah. We usually cut the umbilicus and straight, and we use this only the length of the umbilicus, not increase it from outside. If we want to make inside, we cut the fascia inside, not outside, 1.5 centimeter. We introduce the port, and then we put the trocars. It has a 3 trocars, 1 for the camera and 2 for, and this is the beginning of the series. As you can see, we take the needle and take the gallbladder from down and bring it up. In adults, they are using another also suture at the neck of the bladder, but we have never used it. We don't think that we need it. After that, the dissection is the same as conventional laparoscopic cholecystectomy. You have to clip the cystic ducts, cystic arteries, and cut. And you have always to be sure that you really visualize well. And you don't need to even put the gallbladder in bag or anything, because it's a big, you can just take it from the port itself at the end of the operation. The spleen also you can, and it's really as, so what was our result? We have done 43 sickle cell disease patients underwent SIPS cholecystectomy over 7 years. The mean hemoglobin was 37. Mean age group, hemoglobin S, was 10 years. 24 cases, 56 and 1944 were performed by 8 by fellow and 10 resident respectively. So 9 other procedures were done simultaneously with cholecystectomy and were excluded from the mean operative time. 78 minutes for fellow and 94 minutes for resident. P-value was significant. 1 extra port was inserted in 2 patients at the beginning of the series. And this is just a summary of the results. So in conclusion, SIPS cholecystectomy is safe, feasible, and more cosmetic with almost invisible scar than conventional. More than 1 procedure could be done at the same time. The confusion of crossing image will be adopted after the first 10 to 15 minutes. And SIPS cholecystectomy in children with sickle cell disease is safe and feasible if done by resident under supervision. Stepwise training is essential in this challenging surgery, involving residents with other SIPS procedure, and hands-on MIS single port workshops help them improving their skills. Thank you very much.
Thank you very much, Inam, for your nice presentation. And actually, we are finishing the scientific session. And now, please, Dr. Shireen, can you give the pictures of the last mission? Dr. Shireen?
Maybe she's mute.
No.
شير البتاع.
دكتورة شيرين.
كده اوكي.
ايوه. We can start the photos of the last session mission. النوبة.
اوكي.
خلايا مشاركين. اوكي please. Not yet. شغليه وافتحيها. اوكي. This is the last medical convoy was done in Nubia, which was Hesham there and Sharif Qaddah as part of the community services of the medical faculty. Okay. You can run the video now, please. Okay.
finished.
Thank you, Dr. Shireen. And this was a convoy done at the Sudanese border in the south of Egypt, and they managed almost 5,000 cases in 3 days. And we are coming to the end, but we have 3 words. First will be from Professor Sharif Addah on behalf of the Cairo University team, as he is the chief of Cairo University Pediatric Surgery team now. Please, Dr. Sharif.
Thank you very much, Sharif. You definitely were right. This was a general convoy in Halayb and Shalatin in the furthest south of Egypt on the Sudanese border. It included medical services and veteran services for their camels and for goats, and dentistry under supervision of Cairo University, Professor Dr. Khusht and Professor Dr. Mohammed Sami. And this is one thing I've been proud of, is just contributing to such convoys, and I hope that this was the work of Hesham in the community service. He brought some memories, very good memories in such convoys, and I hope that as colleagues of Hesham, it would be a prime target for us to continue what he's done in public service, community service, education, teaching the pediatric surgeons, the junior staff with workshops and with the science. And I would like also to thank all the participants that participated in this seminar or webinar. And I would like to thank you personally, Sharif, for all the effort you've done. You've been the maestro of this webinar with my eldest brother, Ahmed Midhat Zaki, and Tamer Ashraf, and all the participants. And I have nothing else to say. Thank you very much. Thank you.
Thank you, Sharif. And now, Dr. Shireen, a word from you for Hesham.
I cannot express how much I'm grateful for this memorial webinar for my husband, dear Dr. Hesham Elsaket, who left a legacy of love and integrity with us, his family, and those who knew him. We will not forget his glowing smile, his kindness. He set an exemplary example as a husband, father, friend, and a great surgeon. God bless his soul till we meet again in heaven, inshallah. Thank you all for this great organization for the event. Thank you.
Thank you, Dr. Shireen. And on behalf of the Egyptian Pediatric Surgical Association, EPSA, yes.
Can we just actually observe 1 minute silence in his memory now?
I will put before the closer. You just have 1 minute in advance for me, okay? As usual, okay? Because we are friends. I just will share with you some of the photos with Hesham, and actually on behalf of the EPSA board and the All Egyptian Pediatric Surgery Association, we are missing a leader in our society. And I have to thank all the participants from all over the world. Special thanks to Holger Till and Amr Bouri, Monder Haddad, and Aida Qahtani, and the all attendee with us and the whole administration. And for my co-moderators, Dr. Ahmed Zaki and Dr. Sharif Addah and Tamer Ashraf. I have to share my screen to show some of the photos before we are going now. You see the photos?
Yes.
Yes. This is part of the social life because we are friends for almost 15 years. And we have some of the common things in education. This is in Algeria. And this is during dissertation defense of one of our junior staff, because he was a lovely academic man. And this is the EPSA activities. Okay.
Dr. Sharif, the pictures are in grid view, small size. Please display picture by picture.
Okay. I will do it again.
One by one.
You see it now? Small or big?
No,
In
just
grid view also.
double click on it, it will show. And
double click every picture, yes.
It's okay?
No.
You don't see it yet?
Nope.
You see it?
No, double click every picture, please.
Stop
Okay.
sharing, Sharif. We'll come back again on the slideshow mode.
Okay. You see the picture or not?
Yes, yes.
Yes, now?
Yes, right. Go ahead.
Okay. This is during the dissertation defense of one of our colleagues on minimal invasive surgery. And this is in one of the EPSA meetings. It is the good part with all colleagues from different areas in the body. You can see Hesham in front. And this again in one of the EPSA meetings in the Automobile Club. I think Munde remembers these days. And this is with the Cairo University team, with his colleagues, watching also during one of the sessions and putting remarks as usual. And this is in the IPEC session with in Egypt. Again with some of the IPEC leaders in the region, in the Middle East, with Monzer Haddad and Aida Qahtani. And another meeting in 2017 with Alberto Pena and Dr. Ahmed Medhad and Sharif Qaddah. And this is in London in the Mother IPEC in the board meeting. And we can see Aid, Monzer, Inam, a lot of friends. Again with his wife, Shireen, in London. And this is during last Santiago IPEC, done before the COVID. During discussion as usual with the team, again with Dr. Samah Shahata and I, preparing for the coming 2020, watching for Vienna as weird by Dr. Samah. And this is during sharing session in Algeria. And this is in our part of the workshops in Algeria with the Egyptian team. You those all-time fantastic member of this team with Dr. Gamal Tagi and the group in Al-Kasba in Algeria city. And one of his friends was Murad bin Maryam, and like Mazen Kordi from Saudi Arabia, Murad from Algeria. All this group of these is during the Magharibian Association meeting in Algeria of pediatric surgeons. And a lovely, as he usually like to sit. And this is in Tunisia in the last IPEC Middle East chapter meeting within the Egyptian crew with representation even from Saudi Arabia, from different areas, with Atam and with all of this, and with his soulmate, Dr. Sharif Addah, as they are the same team, and during the defense. And this is the group of the social part of the wives of the Egyptian team in Tunisia journey. Just I want you to get out from these last moments. And actually, this is the last picture because we will have a moment of silence. And you can see Hesham is waving, saying goodbye. And we'll have a minute of silence now for his soul to rest in peace. This is in the LRC, his main home. Can we start the moment of silence, please? I thank all of you in this memoriam, which was, I think, the first to be done in this way. And all of us can pray for Hesham to rest in peace in heaven until we meet him. And thank you all. And we will close our session today. Thank you for all.
Thank you.
Thank you. Goodbye.
Thank you. Good night.
Thank you. Thank you.